Okay, thank you for joining me. Today I'm going to talk about, in brief, about neonatal pulmonary hemorrhage, as I promised. As usual, I have no financial disclosure, and what I'm doing only for educational purposes. The objective of this study to recognize early sign and symptom pulmonary hemorrhage, to describe the pathogenesis and the risk factor of pulmonary hemorrhage, current option of therapy in management of pulmonary hemorrhage, and finally, prognosis and outcome of pulmonary hemorrhage. When we say pulmonary hemorrhage, what does it mean? There is two definitions, either pathologically or clinically. Clinical pulmonary hemorrhage defined as the presence of the blood in the trachea or from the mouth and nose, accompanied by the respiratory distress, which is required increased respiratory support, or intubation within first 60 minutes of appearance of the fluid. Pathologically, pulmonary hemorrhage defined as the presence of the erythrocyte in the alveoli or interstitial or both. If hemorrhage involve at least two loops, defined as a massive hemorrhage. Okay, so we will leave pathological classification or definition. We will focus on the practical. So any condition that when you have a baby who has bleed from the endotracheal tube or either coffee ground blood or fresh blood coming from the tube, accompanied by the increased respiratory support, required more respiratory support, maybe more respiratory distress, and either increased respiratory support or intubation within first 6 minutes of barrier of the blood, then we can say this is the pulmonary hemorrhage. The incidence is usually 1 to 12,000 live births, increased up to the 50 the incidence is 12 per 1,000 live births, increase up to the 50 per 1,000 live births in very low birth weight baby or IUGR infants. So higher risk is the very low birth weight baby, premature babies, and IUGR infants. It's present in 70 to 10% of neonatal autopsies and up to the 80% of very low birth weight infant autopsies. Most commonly occur in the first few days after life and carry highest mortality. Some studies, they said up to the 50%, usually around 30 to 50%. The pathogenesis or the causes of the pulmonary hemorrhage remain unknown. What we know, the hematocrit in the lung obtained in infants with pulmonary hemorrhage was relatively low compared with the whole blood, suggesting that the disorder is due to hemorrhagic pulmonary edema rather than direct injury to the lung. So the most likely cause of the pulmonary hemorrhage is the pulmonary edema. And there are several theories support or explain this process. The first theory that baby usually with severe hypoxemia or because most of the preterm, a lot of preterm, they have the hypoxemia. The hypoxemia can lead to the left ventricular failure. When you have a left ventricular failure, then by the fact that, so that's the heart. When the left side gets respiratory failure, that's the pulmonary vessels. And that's connected to the, so from the aorta, from the pulmonary go all the way to the lung, from the lung carry oxygenated blood to the pulmonary veins. Correct, so that's the left atrium, left ventricle, right atrium, right ventricle, and that's the aorta. So when you have left ventricular failure, what's going to happen? The blood back up, increase all the way back, so increase pulmonary capillary pulmonary or increased pulmonary capillary pressure, and that's increased pulmonary edema as a heart failure manifestation, and that's in pulmonary edema can rupture of the small vessels and can lead to the pulmonary hemorrhage. The second theory, the pulmonary capillary itself is under stress. When it's under rest, the capillary ruptured or breakage, and that's leak of the fluid in the endothelial barrier with leak of the hemorrhagic fluid into the alveoli. So what does it mean? It's the stress itself. So they said the pulmonary capillary, it's under stress. When it's under stress, that's when have a leak. When it leak, the fluid come out and blood come out with the fluid, and that can lead to the pulmonary hemorrhage. The most accepted theory, though, it's about the BDA. As we know, majority of the infant born with the BDA, and more the premature baby. Premature baby usually take time for the BDA to close. So let's think about it. So that's the fourth chamber of the heart, left atrium, right atrium, left ventricle, right ventricle. You have the aorta, you have the pulmonary, you have a BDA. That's called ductus arteriosus. And here you have a lung, pulmonary artery to the lung, carry oxygenated back to the pulmonary veins, correct? Superior vena cava, inferior vena cava. So really, when you have the BDA, as we know, intrauterine, during the fetal life, you have right ventricular pressure higher than left ventricular pressure. After birth, what's going to happen? The left ventricular birth become dominant because you cut the umbilical cord. You drop the pressure on the left side, on the right side of the heart. Babies take breath, everything is open. And then when you have a sudden drop in the pulmonary circulation, the systemic circulation become the heart dominant, and that's send the blood to the entire circulation or entire bodies. Then that's by the time the left ventricle become a dominant. So when the left ventricle become a dominant, baby will have left to right shunt. And when the baby has a left to right shunt, what happens? The blood is gonna go, in addition to the blood from the right ventricle, baby at risk of pulmonary edema. And a baby at risk of pulmonary edema, that's when you have high chance that baby might develop pulmonary hemorrhage. So that's the most accepted theory, that BDA could be the main contributing factor for pulmonary hemorrhage. The other possibilities, surfactant deficiency or dysfunction, and they found the first lung obtained in the neonate with pulmonary hemorrhage. They found that there's significant inhibitory activity against, there's some substance, inhibitory substance, they found it against pulmonary surfactant. Also, if you have pulmonary hemorrhage, also the hemorrhage itself can suppress your surfactant. So that's why it's not clear. Recent theory, intrauterine neutrophil activation. Okay. What's the risk factor for pulmonary hemorrhage? Who are at risk of pulmonary hemorrhage? There is maternal risk factor and there is fetal risk factor. So if the mom has a toxemia, infection, she is cocaine abuse. So cocaine always associated with abruption placenta and also associated with perforation, associated with pulmonary hemorrhage. Mom with bleeding disorder, medication, anticonvulsant, antituberculosis, vitamin K antagonist, lack of the perinatal steroids, preterm labor. So those consider risk factor for pulmonary hemorrhage. What about the infant risk? The most common, as we said, prematurity, IUGR, okay? PDA, we explained already, asphyxia, coagulopathy, hypothermia, polycythemia, bleeding disorder like DIC, baby on mechanical ventilation, which is the stretch, and mechanical trauma, sepsis, Others, male gender, multiple birth, urea cycle. I need you guys to pay attention to the urea cycle. That's the board question, okay? That's why it's very important. If you have baby with pulmonary hemorrhage, you need to check the ammonia level. More recently, surfactant therapy. So surfactant itself can cause to the pulmonary hemorrhage. Meconium aspiration, because it can suppress your surfactant, and also mechanical. Most of those baby need, especially if aspiration, need mechanical ventilation and the risk of the stretch and rupture. Hypotension and required mechanical ventilation in the delivery room. Okay, so those all risk factor, either maternal cause or fetal cause. How surfactant can lead to the pulmonary hemorrhage? And that's what the therapy, I'm talking about exogenous surfactant. I'm not talking about internal surfactant, exogenous surfactant. Exogenous surfactant, it's shown in meta-analysis, randomized controlled trials. That surfactant, as we know, it's very important to improve the compliance. What's compliance? Again, just to refresh, it's delta V over delta B. So when you have low compliance, baby required higher pressure to open the alveoli, or higher pressure to deliver the same type of the, or same tidal volume. So when you have a lung, the alveoli, usually the compliance is very good to keep the alveoli stretching. If there is no surfactant, what happens? The surface tension is very high, then the alveoli is the easily very sticky wall and easily collapse. All of a sudden you give surfactant, what's going to happen? You improve the compliance. Once you improve compliance, you decrease the pulmonary vascular resistance. And once you decrease pulmonary vascular resistance, you increase the left to right chant. And that's when you have the pulmonary hemorrhage. Again, you have the PDA already open, because majority of babies in the first few days, premature babies, the PDA is open. So when you all of a sudden you release or you decrease surface tension, you improve this compliance, you drop further the pulmonary down, the pulmonary pressure. And when you improve the pulmonary vascular or decrease the pulmonary vascular resistance, systemic increase. And that's increase the left to right chant. When you increase left to right chant, then you are high risk of the pulmonary edema, and that's pulmonary hemorrhage. Okay? Hypothermia and pulmonary hemorrhage. We said earlier that one of the risk factors or fetal risk factor is the hypothermia, birth asphyxia and hypothermia. So when baby exposed to the hypothermia, or when the temperature decrease, what happens to the platelets? Platelet aggregation, thrombocytopenia, and then hemorrhage. As simple as that, okay? Good. Okay, so how can I know my baby has pulmonary hemorrhage? As I said early, it has to be either fresh blood oozing from the nose, mouth, or endotracheal tube or trach, or fruity pink, which is coffee grounds secretion, that commonly followed by fresh blood from the endotracheal tube. So that's number one. Number two, you have the worsening respiratory symptoms. Number three, you have the radiological finding on X-ray. So you need one criteria, second, third. So you need triangle. You need number one is the presence of blood. Second, you need to have worsening respiratory distress. The third is the X-ray finding. Okay, what you're gonna see on the X-ray, you might see fluffy opacity, or graviground, or focal, or coffee ground, or sorry, ground glass appearance. So fluffy appearance or opacity, we will show you X-ray later on. Ground glass opacity, or completely white out X-ray. So it's either fluffy, and let's see what does mean here. So that's the fluffy opacity. That's the ground glass appearance. And that's the completely white out X-ray. So either way, plus respiratory symptoms, plus presence of the blood. Some condition even worse, baby start, if you do not fix it early, baby start having hypovolemic shock. Baby starts cyanotic, apnea, hypotension, poor perfusion. Okay, so that's the later symptoms. But the initial symptom, presence of the blood, worsening respiratory distress. When you do X-ray, you will find either fluffy appearance, ground glass appearance, or white out, completely white out. We discussed about shock presentation. It might hematocrit if you do CBC, if you have morning CBC and then you follow with the CBC, you see sudden drop in hematocrit. Or if the baby already on the DIC, then you will see bleeding from the other sides. Okay, very good. What you guys see here, something else wrong rather than the lung white out. Do you guys see it very well? The tube, look at your tube at the carina, correct? So the tube is the deep at the level of the carina. Another X-ray, what's the important in this X-ray? What else you see? It's very important. You will see that hyper expanded chest X-ray. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 almost. Most likely UVC abdomen looks like. And there is another one, UA line. In addition, there is here NG tube, go all the way down, and baby intubated already. Correct? So when you see the X-ray, don't forget you see the whole picture. Do not focus only on the lung, please. Very good. The question now, you have a baby, all of a sudden start having premature baby who's in ventilation. All of a sudden, the nurse, she called you, she said something wrong, there's blood coming out, fresh blood coming out from the endotracheal tube. Initially, small amount, but looks fresh. You look at the baby, baby has some respiratory symptoms. Do I need to do X-ray? If you have it, yes. Otherwise, focus on stop the bleed because that's the true emergency. As I said early, the risk of mortality up to the 50%. So the more proactive you are, is the better for the baby or the increased survival. So the main goal of treatment is the provide supportive care. You need to decrease or you need to stop the bleeding. That's number one. After you stop the bleeding, you need to think of the etiology. Why? Number three, or you can make it number two and then number three. Why? Number two, you need to improve the VQ or gas exchange. And you need to resolve the respiratory distress. More stress is more, we said, damage to the lung. Maybe worsening respiratory distress is more likely to stretching out, more likely to go up on the vent. So you need to, first, I need to give support, try to support treatment, kind of like I need to stop the bleed. I will tell you how. Number two, I need to improve baby oxygenation and ventilation. Number three, I need to think why and the underlying cause. If septic, you need to treat it, etc., etc. So what's the immediate treatment? Number one, you need to, the blood can block your airway. This is the only source, the trachea, it's already inside. This is the only way to deliver the oxygenation. So you need to suction the airway in order to remove the obstruction from the endotracheal tube, correct? Number two, baby already hypoxia. What I'm gonna do? Increase your FiO2. So in order to increase oxygenation, you have either FiO2 or MAP or PEEP, the whole MAP. So go up in FiO2 to improve oxygenation, but the most important single step in this management is to go up on the PEEP. The recommendation is to go up from 6 or up to 6 or 8 range, depending on the baby situation. So whenever, if you are baby on the PEEP of 5, then you go to 6 or 7. Okay, you can go up to the 10, depending on the conditions. Some condition you need to go up in the main airway pressure. If The baby already on the vents, you need to think of that. Go up either by the bib, or if you are on the volume, you need to go up on your tidal volume. So increase your MAB. In very severe, in some condition, you need to, in order to go up in MAB, you need to move the baby to the, or switch the baby to the another mode called high frequency ventilation. High frequency oscillatory ventilation. That's the, in certain condition, you need to move the baby in order to manage the MAB, so you can easily go up on the MAB without overstretching of the alveoli. Again, number one, you need to stop the suction the baby. You need to go up on the pressure on your vents, PEEP. And then if baby hypoxia, go up on the FiO2 to keep your goal to the target. We know that in the baby's preemie, we would like to be 90 to 95%, so that you have the blender, so you can go up on FiO2 at least to keep the baby saturation to that goal. If the condition does not, then you need to move the baby to the high frequency, or you go up on your, if you are using convention, then you need to go up, depending on the either pressure mode that you use, go up on the PIP, or if you're using the volume, go, which is most likely in preemie baby, go up on your tidal volume. Then you think about the causes. You ask, did baby receive vitamin K? If you are not sure, just give 1 dose of vitamin K. You might consider giving dopamine, especially if the blood pressure starts to drop, because dopamine can be, or dopamine has, in addition to the inotropic effect, has the vasoconstriction effect and help resolve the pulmonary edema. What we use, although this treatment is controversially, we give endotracheal epinephrine, endotracheal or nebulizer epinephrine. We use 0.1 ml per kg, 0.1 ml per kg of 1 to 10,000 dilution of the epinephrine. Why? Because it has a vasoconstriction effect. So you go up on the beep, if the baby still bleed, you throw everything what you have. One of the options, you ask for the epinephrine 0.1 ml per kg, 1 to 10,000 dilution, okay? And give it. This treatment, is it based on the randomized controlled trial? No. If you have baby as emergency, you can throw it there, okay? So again, you need to give vitamin K if you are not sure about whether baby is already received vitamin K or no. You might consider dopamine for the vasoeffective or vasoconstructive effect, and also resolve the pulmonary edema. You need to consider epinephrine either through the endotracheal tube or nebulizer for the vasoeffective or vasoconstriction effect. There's another medication has been used for severe hemophilia type A and B called activated recombinant factor 7. What we know about recombinant factor 7, or the name called the Novo 7. It's approval for the severe hemorrhagic or severe hemorrhage in case of the hemophilia A and B. It's relatively low volume. The effect is enhanced when you give the platelet transfusion or with platelet transfusion. If the baby has thrombocytopenia and you decide to treat the platelet by platelet transfusion, then this effect is get enhanced. How it's work? As we know, factor 7 activate the extrinsic. So you have intrinsic factor, you have extrinsic factor. Intrinsic factor start with 13, 12, 11, 9 to the 10 here. And tissue factors, you have factor 7, activate from factor inactive factor 10 to the active factor 10. And that's end up to the fibrinogen to the fibrin. So activated recombinant factor 7 activate extrinsic pathway. So it's not intrinsic pathway, activate extrinsic. So that's called intrinsic pathway, extrinsic pathway. I will show you the picture later on. Which is bind to the tissue, activated factors, and that's the help sealing side of the vascular injury and restore the hemostasis. Again, you have intrinsic pathway, all the factors 12, 11, you have factor 9, and you have factor 8. Intrinsic, the longer. It's easy to remember. The longer pathway, remember, APTT. Very long, APTT. That's the intrinsic. Outdoor, it's called extrinsic. It's just 2 words, PT. That means less factors. You need factor 7, which is stimulate the common pathway, factor 10. And in presence of factor 5, calcium, lipid, activate prothrombin to thrombin, which is activate fibrinogen to the fibrin and blood clot. Make sense? Tissue factor with the factor 7. So you only activate factor 7, recombinant, you activate the tissue factor, which is in turn activate the common pathway. We used only in severe conditions, relatively low volume, which is good. You don't need a lot. You give it 50 milligram per kg twice a day, every 3 hours for 2 to 3 days. The main complication of this medication is the cerebral vascular thrombosis risk. But this risk reported only in adult. Okay? Nothing reported in the newborn. Again, we use the activated recombinant factor 7 only in severe condition that the bleeding does not stop. And we explained the pathophysiology, how it's work. The other condition that you might consider, especially in premature baby where you have severe RDS, surfactant. Surfactant, although we know can cause bleed, but the surfactant administration is can be used also to improve the lung. And that's based on the retrospective case series study of 15 neonates with pulmonary hemorrhage. Those babies treated with surfactant, and they found significant improvement in oxygenation index without clinical deterioration. There's any randomized control saying that surfactant can help for the pulmonary hemorrhage? No. Do we use it? Yes. In case you have the bleed, in order to prevent rebleed, you might consider, especially when you have the issue with your oxygenation, despite go up in the oxygen. So in order to prevent further or the lung getting worse, you need to improve the compliance by giving surfactant. The newest treatment option that we have, it's called homocoagulase. It's derived from the Brazilian snake venom. It has purified mixtures of enzymes. It's very powerful. It has a thromboplastin-like effect that converts prothrombin to the thrombin and fibrinogen to the fibrin. Back to the picture. Help prothrombin to the thrombin and fibrinogen to the fibrin. Okay? So it has powerful thromboplastin-like activity. And this one There's no randomized control trials, but based on the prospective study, there is doses. We don't have exact dose, but based on the studies, they use 0.5 Klobosky unit, or KU. That's the unit that they use for this medication. Usually give through the endotracheal tube every 4 to 6 hours until the hemorrhage stops. Klobosky unit, 0.5. Some articles they use, some study they use even try to use prophylactic 0.25, but what's the most commonly, it's 0.5 KU through the endotracheal tube every 4 to 6 hours until the bleed stop. And that should be used as a last resort if in unresponsive cases, because we don't have a lot of study about this medication and just brand new medication. Part of your management, you need to treat the DIC or thrombocytopenia. If you have the platelet is low, you need to give platelet transfusion. DIC, you need to consider send the labs like CBC, prothrombin time, partial thromboplastin time, fibrinogen, and then consider the FFP if indicated, or cryoprecipitate in some conditions when you have the whole coagulation factors affected. Also, in case because of the bleed, if it's large amount and the hematocrit drop significantly, then you consider blood transfusion. As I said, if the platelet drop, you consider platelet transfusion. Okay. Part of other assessment rather than CBC, BT, PTT, fibrinogen, you need to consider ammonia level in any baby with pulmonary hemorrhage, especially severe pulmonary hemorrhage. Why? Because pulmonary hemorrhage associated, like urea cycle defect, associated with pulmonary, or can be presented with pulmonary hemorrhage. Okay. Outcome and prognosis. As we know, it's depend on the underlying cause. As we know, or as we mentioned earlier, mortality rate up to the 50%. Among those survival, they are at risk of cerebral palsy, cognitive delay, periventricular leukomalacia, seizures. Okay. So, in summary, pulmonary hemorrhage is rare, but life-threatening condition. Rarely caused hypovolemia. Rarely caused by coagulopathy. The most common clinical presentation: large PDA, severe IVH, surfactant, post-surfactant therapy. Aggressive treatment is essential. The most common treatment is supportive treatment, going up on your PEEP or MAP, delta B. In addition to the other trials that we discover, surfactant, epinephrine, endotracheal or nebulizer, dopamine, and then if it doesn't work, you consider the recombinant factor 7 or the final treatment that we discussed, the one come from the Brazilian snake venom, hemocoagulase. Okay. Any question? Any question here? Okay. Hopefully my presentation is very beneficial. Again, the goal is to have the resident understand, or physician understand, how critical pulmonary hemorrhage, how essential to treat pulmonary hemorrhage. The proactive you are, it's better prognosis. And it's very important to think as a, how can I stop the bleed, and then start thinking later on the underlying cause. Okay. Thank you so much for the listening.